What if the most dangerous thing happening to your patient right now is, well, is completely silent?
Oh, that is the scariest part.
Right, because you walk into the room
Yeah.
and the patient is, they're smiling, they're sitting up in bed, happily chatting with their family, they're eating their lunch, and they feel absolutely fine.
Totally normal.
Yeah, but inside, their blood vessels are under so much intense, just relentless pressure that they are quietly sustaining permanent, irreversible damage.
It is genuinely one of the most deceptive scenarios you will ever encounter at the bedside. The monitor up on the wall is telling this terrifying story, but the patient sitting right in front of you looks perfectly comfortable.
And for a newer nurse, that disconnect can be, it can be incredibly confusing.
Oh, absolutely. It's overwhelming.
And bridging that disconnect is exactly what we are tackling today. So, welcome to an episode of the Super Nurse Podcast. Now, we need to be incredibly clear right off the bat. We are not Brooke Wallace.
No, not even close.
Not at all. But we do have access to her incredible brain. So this episode is built entirely from the bedside knowledge, the clinical notes, and, the signature teaching style of Brooke Wallace.
Which is amazing because she is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
Yeah, she really knows her stuff. So our goal today is to help you, the nursing student or the brand new nurse, take all that dense textbook knowledge you're endlessly memorizing and actually translate it into real life-saving patient care at the bedside.
Right. We are taking the theory, stripping away the academic fluff, and just putting it right into your hands for your next shift.
Exactly. And before we get into the actual mechanics of this silent thread, we want to invite you to subscribe and watch the video version of this episode on our YouTube channel, which is Super Nurse AI. The link is right there in the description.
So today's mission is decoding hypertension, high blood pressure. We're going to break down the actual plumbing mechanics of the disease, the massive 2025 guideline updates that are completely changing how the medical community treats it.
It was a huge shift, by the way.
It really is. And we'll cover the subtle bedside clues of a hypertensive crisis and the exact medications and the vital patient teaching that goes with them that you need to know to prevent catastrophic complications.
Like a hemorrhagic stroke.
Exactly.
Okay, so let's unpack this from the ground up. To really understand the interventions, we have to start with, plain English pathology. When we say blood pressure, what are those numbers actually measuring inside the body?
Well, in the simplest terms, those numbers measure two distinct phases of the heart's workload against the resistance of the blood vessels.
Okay.
So the top number, the systolic, is the squeeze. It's the active, forceful pressure inside the arteries at the exact moment the heart contracts to push blood out to the rest of the body.
So systolic means squeeze. I always visualize that as the active pushing phase.
Yeah, that's a really great way to think about it. And the bottom number, the diastolic, is the rest. It's the steady, continuous background pressure in those vessels while the heart is relaxed and refilling with blood.
But when that background pressure gets too high and stays high for years, it literally physically wreaks havoc on the body's plumbing.
It really does.
And what we know from practice is that a great way to visualize this is thinking of the blood vessels like a garden hose.
Oh, the garden hose is the perfect analogy for what you're seeing at the cellular level. If you have a garden hose that is constantly turned on to maximum pressure, the lining of that hose is going to suffer from the sheer force of the water.
It can wear out.
Right. And in the human body, that inner lining of the blood vessels is called the endothelium. When the pressure is just relentlessly high, day in and day out, that delicate endothelial lining develops these tiny cracks and microtears.
And the body, doing what the body does, tries to heal itself and patch those tears up, right? The patching process is actually where the real trouble starts.
Yeah, that is the tragic irony of hypertension. Those little cracks in the endothelium become the perfect resting place for sticky cholesterol and fat that's just circulating in the blood.
Just getting caught in there.
Exactly. The cholesterol gets stuck in the tears, building up over time into hard plaques. And this is the process of atherosclerosis.
Right, atherosclerosis.
So the plaques harden, they physically narrow the vessel, which creates even more resistance for the blood trying to get through, which in turn drives the pressure up even higher. It's just a devastating, vicious cycle.
Which brings us to the massive shift in how the medical community is currently responding to this. Let's talk about the 2025 American Heart Association guideline.
Yeah, we have to talk about this.
Because for a long time, the target numbers we accepted were a bit more lenient. But clinical research, specifically something called the SPRINT trial, really triggered a wake-up call for providers.
It completely changed the landscape of cardiovascular care. I mean, for years, there was this school of thought that as people aged, higher blood pressure was just somewhat natural, and we shouldn't be too aggressive about lowering it.
Yeah, the old let it ride a bit mentality.
Exactly. But the SPRINT trial data showed undeniably that aggressive lowering of blood pressure significantly reduced cardiovascular events and overall mortality.
Wow.
So we are no longer waiting for a blowout to start treating the pressure. The 2025 guidelines take a highly aggressive preventative stance. Normal blood pressure is now strictly defined as anything under 120/80, period.
Period. Okay, but what if that top number creeps up just a little bit? Like, what if a patient is consistently sitting at 125?
If the systolic is between 120 and 129, it's officially classified as elevated. Stage 1 hypertension now starts at a systolic of 130. We are intervening much, much earlier than we used to.
And here's where it gets really interesting for you at the bedside. Why the sudden shift? Like, why the aggressive push to keep numbers so tightly controlled? It turns out it's not just about protecting the heart anymore. It is heavily about the brain.
Right. The evidence tells us that long-term high blood pressure physically degrades the tiny, incredibly fragile microvessels deep inside the brain.
It's so scary to think about.
It is. When we talk about hypertension complications, people usually just think of massive sudden strokes. But we are actually talking about microscopic bleeds and areas of poor circulation that compound over 10, 20, or 30 years.
And that compounding damage leads directly to cognitive decline and vascular dementia. So protecting your patient's blood pressure isn't just about saving their heart, it's literally about saving their memories.
Yeah, it's a profound shift in perspective.
Okay, but I have to push back here, though, because we need to talk about real-world nursing.
Bring it on.
Let's look at an actual bedside scenario. I walk into a room and I have an 80-year-old patient sitting up in bed. They feel perfectly fine, they are talking to me, and their blood pressure is 145/80.
Okay.
If the new guidelines say anything over 120 is dangerous, why might the provider hesitate to aggressively drop that 80-year-old's number down to 115? Aren't we risking them getting dizzy and falling if we lower it too fast?
That is a phenomenal question, and it highlights the exact difference between reading textbook guidelines and using bedside clinical judgment.
Yes, the real world.
Because you constantly have to balance the long-term risk of organ damage against the immediate acute risk of a fall. As people age, their blood vessels naturally become stiffer. They lose that elastic recoil.
Right.
So if we aggressively push that 80-year-old's blood pressure down to 115, they might simply not have enough pressure to properly perfuse their brain against gravity when they stand up.
So they stand up, the blood drops, they get dizzy, they fall. And a hip fracture at 80 years old can be a devastating, life-altering, or even fatal event.
Precisely.
Yeah.
So while the 2025 guidelines aim for less than 120/80 for long-term population protection, at the bedside, we're treating the individual patient's tolerance. We have to balance the theoretical risk of a stroke 10 years from now against the immediate risk of a fall or kidney hypoperfusion today.
You always, always treat the patient, not just the monitor.
Always.
That makes total sense, and that's the kind of critical thinking that separates a task doer from a super nurse. So let's move into what happens when things go from chronic to critical. We call hypertension the silent killer because it's mostly asymptomatic. But how do you know when that chronic high pressure is suddenly turning into an acute, life-threatening emergency right in front of you?
Well, you're looking for the threshold of a hypertensive crisis. Yeah. This is generally defined as a systolic over 180 or a diastolic over 120.
Okay.
But the raw number alone isn't what makes it a true emergency. I mean, a patient might sit at 185 for a week and feel fine. It becomes a hypertensive crisis when end organ damage is actively occurring.
Meaning the vital organs are literally buckling under the pressure in real time. So what are the bedside clues? When you walk in to do your assessment, what is your patient doing or saying that makes the alarm bells ring in your head?
You're assessing for signs that the brain, the heart, or the kidneys are failing to cope with the pressure. So the patient might suddenly complain of a severe, relentless, pounding headache.
Oh, yeah.
They might report blurred vision, extreme dizziness, or suddenly feel very nauseous and start vomiting.
And if we miss those subtle clues, what are the catastrophic complications? Like, what is the worst-case scenario unfolding inside the body?
Well, there are a few catastrophic outcomes. The first is a hemorrhagic stroke. Remember those stiff, plaque-filled arteries in the brain we talked about?
Yeah, the microvessels.
Right. Under crisis-level pressure, one of those weakened, hardened vessels finally just blows out, bleeding directly into the brain tissue. The brain is enclosed in a rigid skull, so that bleeding creates massive fatal pressure.
Terrifying. Just terrifying. And what about the major vessels near the heart?
You have to watch out for an aortic dissection. This is where the inner layer of the aorta, the massive main artery, leaving the heart literally tears from the high pressure.
Oh, God.
Yeah. Blood surges into the tear, separating the layers of the artery wall. And the classic bedside clue for this is a patient suddenly screaming about a tearing or ripping pain right between their shoulder blades.
And then there is the slow motion catastrophe that takes years to develop. Heart failure. I want to spend a second here because I think the mechanical why behind this gets lost for a lot of nursing students. How does high blood pressure in the arms and legs actually cause the heart to fail?
Let's go back to the physics of the body. If the arteries all over the body are clamped down, narrowed by plaque, and full of high pressure, the left ventricle of the heart has to work incredibly hard to push blood out against that massive resistance.
Okay.
So think about what happens to any muscle in the human body when it is forced to work too hard against heavy resistance every single day.
It bulks up. It gets bigger, like a bodybuilder lifting weights.
Exactly. In the heart, this process is called concentric hypertrophy. The muscle wall of the left ventricle bulks up and grows thicker. But here is the fatal flaw in that process. The heart muscle can't expand outward because it's encased in the pericardial sac. So it grows thicker inward, crowding into its own chamber space.
Oh, wow. So it's like a bodybuilder living in a tiny closet. The muscle gets so huge that there's physically no space left in the room.
That is a brilliant way to visualize it. The heart muscle becomes thick, stiff, and much less compliant. Because the chamber space is now so much smaller, it physically cannot fill with enough blood during the resting phase.
So the cardiac output drops.
Exactly. And fluid backs up into the lungs because it has nowhere else to go, and you have severe diastolic heart failure, all caused by years of silent high pressure.
Okay, so as a nurse, you walk in, you look at the monitor, and you see a blood pressure of 190 over 110. Your patient says their head is pounding. What is your immediate nursing action? Because, a newer nurse might panic and immediately start pulling medications.
And an experienced nurse knows to pause and verify the data. Clinical experience shows that machines can be wildly inaccurate.
Oh, all the time.
The cuff might be the wrong size, or the machine might just be glitching. So your very first action is to take a manual blood pressure yourself.
Yes. You have to trust your own assessment. And you need to ensure the patient is positioned correctly. Make sure they have rested for 5 to 10 minutes, ensure they aren't talking during the measurement, and crucially, make sure their legs are uncrossed. A crossed leg can actually artificially inflate the reading by several points.
Yeah, that's a great tip. And once you've done your manual check and confirmed that the dangerous number is real, you notify the provider and you prepare to fix the plumbing.
Right. And we don't fix the plumbing with wrenches. We fix it with pharmacology. The provider is going to order medications, and you cannot just be a task doer who scans the barcode and hands over a cup of pills. You need to know exactly how these chemicals alter the body's mechanics.
You really do.
So let's break down the ABCDs of cardiac pharmacology, focusing on how they solve the plumbing problems we just talked about.
Let's start with A. ACE inhibitors, which end in prol, like lisinopril, and ARBs, which end in sartan, like losartan. These drugs are targeting the resistance in the blood vessels.
I always think of these as the chill pill for the cardiovascular system. They block the renin-angiotensin-aldosterone system, or the RAAS pathway. Essentially, the kidneys usually produce chemicals that tell the blood vessels to constrict and hold on to water. ACE inhibitors block that chemical cascade. The vessels relax, they dilate, and the pressure naturally drops.
That's the exact mechanism.
Yeah.
But what is the bedside reality? Like, what is the patient going to complain about? Because ACE inhibitors have a very famous maddening side effect.
The persistent dry cough. But wait, I'm actually a little confused on the mechanics of that. Why does a blood pressure medication specifically cause a cough in the lungs?
It's a fascinating quirk of the chemistry. The enzyme that ACE inhibitors block is also responsible for breaking down an inflammatory substance in the body called bradykinin.
Okay.
So when you block the enzyme, bradykinin builds up, specifically in the lungs. It irritates the respiratory tract, causing a dry, hacking cough. It's clinically harmless, but it can drive a patient absolutely crazy and cause them to just stop taking their meds.
Which is bad.
Very bad. If it's unbearable, the provider will usually switch them over to an ARB, which dilates the vessels to a slightly different pathway and avoids the bradykinin buildup.
That makes so much sense. But you also have to watch for the rare but far more dangerous side effect of an ACE inhibitor, which is angioedema, severe swelling of the face, lips, and tongue. It can compromise the patient's airway in minutes.
Yes, very scary.
And you also have to watch their lab values, specifically potassium, right?
Because of how they interact with the aldosterone hormone in the kidneys, ACE inhibitors and ARBs cause the body to excrete sodium and water, but they cause it to hold on to potassium. So you constantly have to monitor the patient's labs for hyperkalemia, which can trigger lethal heart arrhythmias.
Okay, so A fixes the tight vessels. Now for B, beta blockers. These end in olol, like metoprolol. How do these fix the plumbing?
If ACE inhibitors relax the pipes, beta blockers pump the brakes on the pump itself. They block the beta receptors of the sympathetic nervous system, the fight-or-flight response.
Okay.
So adrenaline can no longer bind to the heart muscle. This drastically slows the heart rate down and reduces the force of contraction, which lowers the overall workload on the heart muscle.
And the cardinal bedside rule here,
Yeah.
you always check the patient's apical pulse for a full 60 seconds before giving a beta blocker. If the heart rate is under 60 beats per minute, you hold the medication and call the provider because you don't want to slow down a heart that is already bradycardic.
It is a non-negotiable step in your assessment.
But here is where it gets incredibly tricky. And this is a massive clinical pearl for newer nurses. Because beta blockers stop the heart from racing, they can completely mask the symptoms of hypoglycemia in diabetic patients.
Yeah, it's a connection a lot of people miss until they see it at the bedside.
It's wild.
Think about what happens when a patient's blood sugar crashes. Their body panics and releases adrenaline to warn them. Their heart starts pounding, they get the shakes, they sweat. But the beta blocker puts a chemical lid on that adrenaline response.
So they don't feel it.
Exactly.
Yeah.
A diabetic patient could have a dangerously low blood sugar of 40, but their heart rate stays a calm, steady 65. You have to be hypervigilant with your blood sugar checks.
That is huge. And you also have to be very careful with patients who have asthma, because non-selective beta blockers don't just block the receptors in the heart, they also block the receptors in the lungs, which can trigger severe bronchospasms and worsen their breathing.
Yep. So let's look at the C calcium channel blockers. These often end in alpine, like amlodipine, or include drugs like diltiazem. These are kind of a two-for-one deal.
Explain the mechanism to me. Why do we care about calcium in the blood vessels?
At a cellular level, calcium is the literal trigger that causes muscle fibers to contract. If you prevent calcium from entering the muscle cells of the heart and the arteries, the muscle simply cannot contract as forcefully.
Oh, gotcha.
Yeah. Less calcium means a weaker, calmer heartbeat, and it means the smooth muscle in the blood vessels stays relaxed and wide open.
Bedside reality for calcium channel blockers. You really have to watch for orthostatic hypotension. Because those vessels are kept so artificially relaxed, when the patient stands up quickly, the vessels can't quickly constrict to pump blood to the brain. Right. Gravity pulls the blood down, and the patient can easily pass out. You have to teach them to change positions very slowly.
And you also have to teach them to strictly avoid grapefruit juice.
Wait, okay. I remember learning this for the NCLEX, but tell me why grapefruit juice is so dangerous with these specific meds.
Grapefruit juice contains compounds that completely block a specific intestinal enzyme called CYP3A4. That enzyme's job is to break down the calcium channel blocker so your body processes a safe amount.
Okay.
So if you block the enzyme with grapefruit juice, the medication isn't broken down. It builds up to toxic overdose levels in the bloodstream, which can completely crash their blood pressure.
Fascinating. You also need to warn them about some of the weirder side effects, like severe constipation or gingival hyperplasia, which is swollen, bleeding gums. Good oral care is an absolute must. Which brings us to D-diuretics. Drugs like furosemide, hydrochlorothiazide, and spironolactone.
If the other drugs fix the resistance or the pump, diuretics fix the fluid volume. These are the dehydrators.
The water pills.
Right. They force the kidneys to pull excess fluid volume out of the bloodstream and excrete it as urine. Less physical volume inside the pipes means less pressure pushing against the walls.
And the main character in the diuretic story is potassium. You have to know exactly what kind of diuretic you are giving. Is it a potassium-wasting diuretic, like furosemide, or a potassium-sparing one, like spironolactone? If they are wasting potassium, you need to be encouraging foods like bananas and spinach, or checking their chart to see if they have a potassium supplement ordered.
And here's a highly practical bedside tip regarding diuretics and the ACE inhibitors we talked about earlier.
Okay, lay it on me.
If your patient is already taking a daily diuretic, their fluid volume is already depleted. If the provider then orders their very first dose of an ACE inhibitor, that sudden vasodilation combined with low fluid volume might cause their blood pressure to completely bottom out.
Wow, okay. So how do you manage that safely at the bedside?
You advocate to give that first dose of the ACE inhibitor at night, right before bed. That way, if their pressure drops significantly while their body adjusts, they're already lying down safely in bed, completely mitigating the full risk.
See, that is exactly the kind of bedside logic that makes a super nurse. Okay, so we've covered the plumbing, the crises, and how the ABCDs fix the mechanics. I want to spend our last few minutes on patient teaching.
Very important.
Because, handing the patient a cup of pills and charting it is only half your job. If they go home and don't actually understand their disease, they are going to end up right back in your ICU.
And one of the biggest challenges you will face as a nurse is medication adherence. Patients very frequently want to stop taking their blood pressure meds.
Yep.
And if you think about it from their perspective, it makes sense. The high blood pressure itself had no symptoms. They felt totally fine. But then you give them medications that make them pee constantly or feel dizzy when they stand up or give them a hacking dry cough.
So from their point of view, they feel significantly worse on the meds than they did before they came to the hospital.
Exactly. And your job as a nurse is to validate that frustration, but explicitly explain why they cannot just abruptly stop taking the pills. Stopping these medications cold turkey causes a massive physiological backlash called rebound hypertension.
Oh, that's bad.
The blood vessels violently constrict, and the pressure skyrockets even higher than it was before they started the meds, which is a massive immediate trigger for a hemorrhagic stroke.
We also have to teach lifestyle interventions. It's not just about popping a pill to fix the plumbing. We need to teach the DHH diet, which is high in vegetables, fruits, low-fat dairy, and crucially, low in sodium.
The sodium restriction is vital, and you need to explain the why to the patient. Tell them that sodium acts exactly like a dry sponge inside their blood vessels.
The sponge.
It aggressively pulls water into the bloodstream and holds on to it.
Oh.
More water volume trapped in the confined space of an artery equals dangerously high pressure.
But what the evidence tells us is that we can't just put all this burden on the patient alone, expecting them to fix it with willpower. The 2025 guidelines heavily emphasize team-based care and utilize a new tool called the Prevent Risk Calculator. What does that actually do?
Well, the Prevent Calculator is a major update. Instead of just looking at immediate risk, it looks at the patient's 10 to 30-year risk for cardiovascular disease, factoring in things like kidney function and metabolic health.
Okay.
It shifts the entire clinical focus to their long-term trajectory. And because hypertension is so complex, the guidelines mandate a whole team approach to manage that trajectory.
Meaning it's the provider diagnosing, the nurse educating and monitoring the ABCDs, the pharmacist adjusting dosages, the dietitian helping them navigate the DIAS-A diet, and social workers addressing the root environmental causes.
It requires a village. I mean, you can't just hand a patient a pamphlet on a low-sodium diet and expect success if they live in a food desert and only have access to highly processed, cheap, sodium-packed foods at the corner store.
Absolutely not.
Social determinants of health are a massive, unavoidable piece of the hypertension puzzle.
So as we wrap up, what does this all mean for you, the nurse standing at the bedside during your next shift? Let's summarize the core lessons here. The main takeaway is that hypertension isn't just an arbitrary number you memorize to pass the NCLEX.
It is the physical, relentless wear and tear on your patient's delicate blood vessels that leads directly to strokes, heart attacks, and vascular dementia. It is a mechanical problem that requires precise, thoughtful intervention.
Remember Brooke Wallace's golden rule. Treat the patient, not the monitor. Confirm that high number with a manual cuff. Keep your eyes open for the subtle early signs of a crisis. The pounding headache, the dizzy spell, the tearing back pain.
And critically, know exactly what your ABCD medications are doing to the patient's fluid volume, their electrolytes, and their heart rate before you hand them that cup of pills.
Yes, think before you give it.
Anticipate the physiological shifts and teach the patient how to manage the side effects safely so they actually stay on the medication.
I want to leave you with one final fascinating concept to mull over before your next shift. We briefly mentioned the social determinants of health, but it goes so much deeper than just access to healthy food. The 2025 guidelines highlight something profound. Your environment literally alters your biology.
It is a powerful realization that changes how you view patient care entirely.
Think about it. If a patient lives in a highly stressful environment, maybe they are dealing with intense financial strain, a lack of physical safety in their neighborhood, or chronic daily anxiety, their brain's amygdala is constantly firing.
Right.
The brain thinks the body is under physical attack, so it pumps out stress hormones like cortisol endlessly.
And over the course of decades, that relentless daily flood of cortisol physically inflames the endothelial lining of the arteries. It accelerates atherosclerosis, stiffens the vessels, and drives the blood pressure up, creating a direct biological link between a stressful life and heart disease.
Guarding your peace, managing your stress, and protecting your environment in your 40s is quite literally how you protect your blood vessels and your memory for your 80s.
It's the ultimate preventative medicine.
It really is, and it makes you look at every patient's chart with a little more empathy. Thank you so much for joining us for this episode of the Super Nurse Podcast. Please remember to go watch the video version on YouTube, like, subscribe, leave us a comment, and visit supernurse.ai for great resources to help you become the super nurse you were born to be. Catch you next time.